Our case is titled Cryptococcus neoformans pneumonia mimicking COVID-19. Cryptococcus neoformans are poorly encapsulated yeast that become infective through inhalation by depositing into alveoli and bronchioles. Patients are asymptomatic in the majority of cases, with symptomatic infection occurring in immunocompromised patients with HIV or on immunosuppressant therapy. In these patients, Cryptococcus neoformans causes symptomatic infection by escaping from granulomatous complexes, causing meningoencephalitis, pneumonia, and acute respiratory distress syndrome. The most common symptoms include cough, hemoptysis, sputum production, fever, chest pain, fatigue, and weight loss. Given these nonspecific symptoms and the fact that CN has a multitude of different presentations on imaging, it has often been described as a great mimicker. Here we describe a case of cryptococcal pneumonia, which eluded diagnosis because our patient's presentation was similar to another mimicker, COVID-19. So our patient was an 82-year-old male with a history of Crohn's disease on prednisone who presented for an elective ablation of chronic atrial fibrillation. The following day he was discharged but readmitted due to fever, cough, and shortness of breath. The patient had neutrophil predominant leukocytosis, tachypnea, and a temperature of 100.4. Chest x-ray showed mild interstitial edema, and tests for COVID-19 and influenza were both negative. The patient was known to have a history of heart failure with preserved ejection fraction and was treated with maintenance diuresis, along with broad-spectrum antibiotics for concern for bacterial pneumonia. However, his respiratory status declined from nasal cannula to positive pressure ventilation over the course of a week. Because the patient's symptoms were similar to that of COVID, he was retested a total of 3 times with negative results. Patient's sputum was sent for bacterial, AFB, and fungal cultures multiple times, which failed to isolate any pathogen besides nonspecific yeast. Multiple infectious serologies were drawn, which finally yielded a positive cryptococcal antigen test. HIV test was negative. However, patient did demonstrate immunosuppression with CD4 count less than 200. He was treated for severe cryptococcal pneumonia with amphotericin B and fluconazole. But despite treatment, his respiratory status and mental status continued to decline, such that he required maximal support on BiPAP and remained encephalopathic. Eventually, his family made the decision to pursue comfort care. So in conclusion and discussion, our case is unique as it represents a case of Cryptococcus pneumonia in the era of COVID. While COVID has many clinical manifestations and imaging findings, so does Cryptococcus. Patients that develop severe symptoms are almost always HIV positive or status post-transplant. The source of immunosuppression in our patient was Crohn's disease, with daily prednisone placing him at increased risk of disseminated infection. This case highlights an infrequent situation arising in the age of COVID and the use of steroids. With COVID encompassing a large amount of hospitalizations, it can overshadow other causes of systemic infections. With patients on chronic steroid therapy, fungal infection should be prioritized. And attached, we have some images of his chest x-ray on admission and his x-ray taken later in the course. Thank you for listening.